Good afternoon, everyone. Welcome and thank you for joining this 1 hour live training session for troubleshooting the MyoSure and Aquilex system. This will be followed by a 15-minute question and answer session, but we appreciate that it's quite a long time and you're most probably very busy, so we'll try and move it on a little bit quicker if we can. My name is Simone Stevenson, and my name is Simone Stevenson. I'm the Hologic Application Specialist for the Midlands and North West, and my colleague Stacey Tatum, and I will be doing the training today. I'm based in Staffordshire and Stacey's in Colchester. Stacey and I are part of a 5 team, which we are clinical application specialists in the UK, whose primary role is to educate and train customers on the use of our equipment. Now, during these challenging times, we're trying to help customers by offering these web-based sessions to minimise the footfall within your hospital. We're working from home, so I hope you appreciate that the quality of the video feed is not perfect, but hopefully it'll be good enough. Right, so today our agenda will be, we'll review the Aquilex and the MyoSure troubleshooting. We'll have some live demonstrations from Stacey, and then 15 minutes Q&A session at the end. So we will be providing training certificates for all the attendees. If you're actually viewing in a group, so maybe the 2 or 3 around the same laptop, so you're sharing the same device, could I please ask you to email us with the attendees' names so that we can prepare a certificate for them? I'll show you the email address shortly. If you have any questions for Stacey and I during the session, you can write your questions in the following ways. If you're watching on your phone or iPad, all you need to do is tap on the screen and you'll see 3 dots. Tap on the 3 dots and you will see the screen that's shown. Just click on the Q&A and then type in your question. If you're watching on your laptop, then just click on the Q&A button on the top right-hand side of the screen and type in your message. And we'll aim to try and answer all the questions at the end of the 15-minute live Q&A session. Okay, so we are still working and available, so if you would like support from the Hologic team, please email us at the following email address, which is ukpnsurgical@hologic.com. So we're going to do a quick overview on the equipment. So I'm going to pass you over to Stacey, and then what will happen is I will then put the questions up, which are sort of common shooting questions we get, and Stacey then will show you on the screen, and then I will confirm them. Thank you. Over to you, Stacey.
Thanks, Simone. Hi, everyone. So I just wanted to give you a quick overview of what the machine actually does and how it works. So we've already got it set up. So what the machine is going to do for you is pump in fluid at a pressure that you set to enable the consultant to see and create a tamponade inside so it doesn't bleed. And whilst it's doing that, so there's 2 types of scale that we have with this machine. There's one with this backboard like this, and this one will weigh the fluid in the bag, and it will weigh the fluid. So it's weighing the fluid that goes into your patient, and then it's sucking it back using the suction from here, and it's weighing what comes back. So what is missing, it assumes your patient has absorbed, and it will give you the deficit in here. If your one doesn't have a backboard, then your pump will be counting the fluid that goes around this wheel here. But it does the same thing on the suction. It sucks it back, and then it will weigh what comes back. And again, what is missing will be in this window here, and it assumes your patient's absorbed. So as long as you've got a decent under buttock drape, everything's falling into it, this number will give you an accurate fluid deficit of what your patient has absorbed. And back over to you, Simone.
Right, thank you. Right, so common troubleshooting hints and tips. So we're going to put up some common scenarios, and like I said, I will then pass you over to Stacey so she can actually show you the practical side of it on the machine, and then I will confirm the answers on the screen for you. So, first scenario, during the procedure, visualization is lost. What should we do? Over to you, Stacey.
Thank you. So when they're talking about visualization, they're talking about what the consultant can see. So we're saying if it starts to bleed, what should we do? And the first thing is just to wait. Okay, the tamponade will push back the blood into the vessels. But what we need to ensure that the consultant does is keeps the cutting window away from the tissue, but actually out in the cavity. So if I can just show you, a lot of the time, this little black line here, because they can't see, they will draw this back down the scope, and then they've lost their suction. So they need to push it back in, keep it away from the tissue, and just let it do its suction and suck that blood clear. If that doesn't work, then you can increase the pressure, which is just here. Let me bring it a bit closer for you. So you can increase the suction with these keys here. It goes from 40 right up to 150, and it goes up in increments of 5. Give that a second to work. If that doesn't improve, then you can come around the back of the machine. So I've just got to be careful of all my wires here. And there's a suction dial at the back that we can we keep that on around about 2 o'clock. Just be very careful as I pull my wires out. It's just here. We start it off around 2 o'clock, and we can just close that suction down just to build up the pressure inside the cavity. Round again, and then again, you wait a little while, and then if that doesn't work, then the last option is to keep the the cutting window in the cavity and just tap the foot pedal slightly, and it will just suck out some of the water, but that is our last resort. Over to you, Simone.
Yeah. Okay then, so just to confirm, first thing, wait, be patient, and allow the tamponade effect to clear the view. Increase your pressure and reduce your suction. Draw the device away from the tissue so the cutting window is visible, and activate the foot pedal. Do not keep your foot on the pedal continuously, as it will cause loss of distension and reduce visibility further. Okay, so after all attempts, there is still no improvement, Stacey, so what can I do now?
What you should do is check you've actually unclamped your bag and there's fluid going in. Make sure there's no kinks or anything like that in the tubing, and just check that your suction's working properly, because if your canisters are full or if they're not sealed down tight, it's not going to draw the suction back and it will get quite murky inside. So just go around making sure everything's sealed down tight. Your surgeon hasn't rolled over the yellow tubing with their stool, nobody's standing on it, it hasn't got a kink in it, it isn't over the patient's legs, and check all your suction, and that should help visualization as well.
Thank you. So, Stacey said, check there's no kinks in the tubing, check that the tubing isn't trapped under a chair, make sure the fluid bag clamp is released fully, and check the suction is working properly, so that the suction clamp and that the canisters are sealed properly. This is most probably one of the most common errors, that the canisters aren't sealed properly. Right, so next question. Fluid runs dry, pump wheel is racing, and my fluid deficit is increasing rapidly. What can I do? Over to you, Stace.
So the first thing to do, the first thing that you'll hear when that happens is a flat tire noise, like a, and that's usually because your fluid bags run dry. If that happens, either get the surgeon to close off the blue tap here, or if it's quicker, just put your pump in pause mode with this button here. And then you would hang a new bag, make sure it's unclamped. If the fluid has gone all of the way out of the tubes, the machine might ask you in this little window here to prime again. If it does that, you would need the machine in pause mode. You would need to press the prime key, hold it down until it asks you to prime, and then go through the prime process. And then that will purge the line with air and give you back its ability to be able to feel the pressure inside the cavity. So you may have to, if it hasn't, then you probably won't. You'll just be able to get on with it.
Thank you. Right, so first step, we can close the inflow stopcock or pause the system, hang more fluid, restart pump, or open the stopcock. Now, note that the fluid deficit will no longer be accurate due to turns of the pump without fluid. So perhaps estimate around about 1 to 200 discrepancy. Our next question is then, the fluid deficit is increasing very rapidly. High fluid loss. Is everything okay? Tuesdays.
Hi there. Right, no, it's not. So the first thing you would need to do again is put the pump in pause mode or get your surgeon to turn off the blue tap. What's happening is you will see a little sign in this window here that says high fluid loss, and what the machine is trying to tell you is that it's pumping fluid into your patient and nothing's coming back. So it's alarming to let you know. It's alarming so that you will check where this fluid has gone. So the likelihood is it's sitting in your under buttock drape, and that could be for a lot of reasons. So you just need to check all around. So the first thing I would do is check my under buttock drape, check that the yellow outflow channel that's removed from the scope at the beginning is turned in the off position. If it isn't, it will just suction air and leave all your fluid in your under buttock drape for you. Make sure there's no clots or anything sitting in your bag blocking the little tap at the bottom. Make sure your consultant hasn't chucked the cotton wool in there and that's blocking its route. And then just make sure that your drape is hanging vertically and it's not folded, because the water will sit on top and not come through the tap at the bottom. Check that your clamp on your yellow tubing is undone. And just like we said before, check there's no kinks in it, check nobody's standing on it, check that the surgeon hasn't rolled their foot pedal on it. I know as nurses, we like to hang things over patients' legs. We don't like things draping on the floor. But for this yellow tubing, it's waste tubing. It does need to go onto the floor. Then we're going to come back to our canisters and make sure everything's sealed down tight. Make sure all your lollipops are lined up. Those that saw our last training will know what that means. And make sure your canisters aren't full. If they are, it will not suction anything back. It doesn't alarm to let you know. You need to keep an eye on it. If you do need to change your canister, if you've only got a little bit of pathology left to take, then I would just change the back one. But if you're only halfway through your procedure, it might be as well to change both canisters at the same time. So to change a canister, you either put the pump in pause mode or you just tap on the canister itself. That's going to pause your machine for you, but you need to let your consultant know what you're about to do, because it doesn't just pause the suction, it pauses the pressure and the water going in. So to change your suction, can you see my canister, Simone?
Yes. Yeah.
So I would take the tandem tubing out first, put that straight into your new one, pull the back one out, and then put the new one in, remembering to line up the holes in the canister and the canister liner. If you can, take it off the canister, take it off the scale so it doesn't crack. And then once it's all sealed down tight, I just press the resume, let the surgeon know what I'm going to do, and then they can carry on with the procedure.
Okay, so as Stacey said, check the fluid is being suctioned effectively. not caught in the under buttock drape. Also, check the fluid is not being lost on the floor. Now, this is quite often, I would actually, if I saw my high fluid loss come up, that's the first thing I look for, to see fluid leaking on the floor, to be honest. So you need to make sure that that under buttock drape is right under the patient's bottom. Also, check that the canisters are not full, and then alert the consultant if the fluid has been collected and the deficit is accurate. Because obviously, if that is the case, then this patient is absorbing fluid too quickly. So according to the 2016 ESGE guidelines, up to 2.5 litres saline deficit is within safe limits for a fit and healthy patient. But obviously, before you actually start the procedure, you need to just check with your consultant or the anaesthetist to what fluid deficit they want set. Thank you. So next question, we're removing the polyp. Do we need Aquilex? What can I use?
So the answer is no, you don't necessarily need the Aquilex, although it is best practice because it's keeping an eye on the fluid deficit. But you can use the MyoSure on small pathology with a pressure cuff and some sort of a suction canister. So whether it's a carousel or wall suction, you can use it that way. But for big pathology, then you should have a fluid management system, definitely.
Okay, actually, so like Stacey said, no, you don't have to. Some units only use Aquilex for larger pathology. You can use a pressure cuff, tissue trap, on adjustable suction, which is sufficient for polyps, or if you've got wall suction, or say a little portable suction unit. We are actually going to be doing a webinar on easy setup in the next couple of weeks. I think it's on the flyer that we have. So if you're interested in seeing this, then please join us. So the next question, if the MyoSure appears to be struggling to remove the pathology, what can we do to help?
Thanks, Simone. So as I said earlier, the machine uses suction to suck the tissue to this little cutting window here. And the 2 o'clock that we start off with at the beginning is usually enough to draw that tissue to this window. But sometimes the pathology is a little bit tougher, so we just need a little bit more suction. So it could be that the top of the pathology is nice and soft. We're cutting it with the suction at 2 o'clock, but as we start to get to the base, it starts to get a little bit harder. So this suction dial, we can turn this up. I would turn it up in small increments. So I wouldn't just take it straight up to high, but I take it up in small increments and see how that feels for the surgeon. And again, when you turn them up, just give it a few seconds to build that suction up. If that doesn't help, then again, make sure that all your canisters are sealed down tight. There's no kinks in your tubing, what we've been through before. You can check at the back of the pump as well that the suction is actually working. So you won't be able to see too clearly, but there's 2 little gold valves at the back here, and they will intermittently blow out air, and that's normal. And if it's doing that, then you know that the machine's fine. It's something probably to do with your tubing. And also check your reusable tubing. If there's any water or condensation in these, you will need to get rid of them. The machine won't work properly. And just lift them up to check. There's one on either side. So it's always worth having 1 or 2 extra sets on your shelves, because if you're halfway through a case and this gets water in and you haven't got another set, then you're not going to be able to carry on with the Aquilex. So tip, keep a spare pair on your shelf.
Right, so increase suction, ensure your canisters are not full, ensure suction is working properly. And like Stacey said, you've most probably never noticed them before, but on the back of the actual machine, there are 2 little gold holes, if you like, and you will feel the air pumping out of there. So if there's no air pumping, then yeah, there is a problem. Make sure the canisters are sealed and tubing is connected correctly. And the vacuum tubing filter is not wet. Like Stacey said, it is always useful to just keep one spare set of those on your shelf. So our next question, when might I need to increase the pressure? Over to you, Stace.
So pressure is all about vision. So if you go in and it's the pressure, the 80 pressure that's default isn't enough to open up the cavity, then the surgeon may ask you to increase the pressure. If they're going through the procedure and it starts to get murky inside or it starts to bleed a little bit, then again, the surgeon will ask you to increase the pressure. You should always cover yourself and just ask them what they would like it increased to. And when you've done that, just call back to them and say, if they've asked for 100, Mr. Consultant is at 100.
Right, so when visualization needs to be improved, increase the pressure. When tamponade is needed to stem any bleeding vessels, and when I have increased the suction. So our next question, when might I need to increase the suction?
So the suction dial that we were talking about is for cutting power. So when you need to increase it, when the tissue isn't being drawn to the cutting window and the cutting efficiency isn't great. So when the consultant says, oh, it doesn't feel like it's cutting properly, they will ask you to turn up the dial at the back, the suction.
Okay, so nice and simple. To improve cutting efficiency on the device, especially on fibroids. As we know, the fibroids can tend to be a little bit more calcified, so it usually needs a little bit more help, hence why we need the cutting window to be close to it, and the suction will help actually suck the pathology into the cutting window. So our next question, how do I find out how much fluid I have used in total?
So this is for those times that you have gone through quite a lot of fluid, there's fluid on the floor, there's fluid in your canisters, and you need to guesstimate how much your fluid deficit is. And there's a little trick with the machine. So if you press the up and down keys under the fluid deficit together at the same time, that will give you how much fluid has gone inside your patient. So that is minus that first prime that we had. So it's actually how much fluid is going inside your patient. And then you can work out how much you've got on the floor, how much you've got in the canisters to give you a near accurate fluid.
Right, so hold the deficit up and down buttons together, and that will give you your total amount of fluid that you've used. I think this is worth mentioning again though, rather than having this problem, having to try and figure out fluid deficits, make sure that you've got decent under butter grade and that it is right under the patient's bottom. So our next question, what should the variable vacuum be set at the beginning of the procedure?
So again, that variable vacuum is the dial, the suction dial at the back, and we want to start it off around 2 o'clock. There's usually a nice sweet spot for starting procedure, and that's 80 at the front, 2 o'clock at the back. We can adjust them as we go through, but for starting, that's what it should be.
Okay, so begin at low and increase necessary for effective tissue removal. Remember, you may need to increase the pressure when you increase the suction. So when I connect the MyoSure device to the tissue trap, the pump stops. Why is this?
So It's supposed to do that, and that's because when you connect your device to the tissue trap, you're putting a weight on the scale. So it wants to know where this weight's all of a sudden come from. So it's going to stop and check. And also, it will think that you want to change one of these canisters, because like I said at the beginning, when I talked about changing canisters, you can either pause it or just touch it and it thinks you're going to change one. So it's natural for it to do that. If you do it by accident, if you kick it, if you see on their front of the screen canister change, it means somebody's actually accidentally touched it. It's not a problem. Just press the resume key and the procedure will carry on.
Right, so the scales weigh the fluid, the sensitive to touch. Press the resume button to continue. Simple. So the pump alarm with high fluid loss. What does this mean? Pump's alarming.
So again, we've already been through it, but it's really good to reiterate. It means it's pumping fluid in and nothing's coming back. So it wants you to check where that fluid is. So we do all the checks again. We check the floor, we check our bags, we check the tubing, we check our canisters, we check nothing's in the under buttock drape. But really what it's saying, if you can't find it, is find the fluid. If you can't find it anywhere, then you have to assume it's gone into your patient. You need to check your fluid deficits to make sure we're not overloading the patient. So high fluid loss, it's a safety thing to say, check where your fluid is. If you found it, you can carry on with the patient. If you can't find it, then you've got to assume your patient's absorbing quite quickly, and you need to keep a very serious eye on your fluid deficit, and they shouldn't go over the limit that's set.
Okay. So what it's saying is there's been an above average amount of fluid in versus fluid out. So check for leaks and consider absorption levels of the patient. Our next question then. Do I have to pause the system to change the fluid bags?
No, it's accumulative, so it knows what it's doing. There are 2 spikes, so you can hang 2 bags, you can spike 2 bags, but only ever have 1 bag running at a time. So keep the one you've spiked closed, and then just the one that you're using run free. And then when this one runs out, you unclamp the other one, clamp that off. So the answer is no, you don't have to. If you have one of these new carton scales, please leave the bags on, because it weighs. It's going to weigh the bag as well as the fluid. So just keep those on, don't take those off. So the answer is no, you don't have to.
Okay. Thank you, Stacey. Will the deficit calculation be affected?
How many bags of food you've gone through when it's weighing, and it just accumulates the number of bits calculating around the wheel. So no, you don't have to do any adding or taking away. It will do it all for you.
So Stacey says no. Deficit is cumulative based on the pump rotations and weight of fluid out. So next question. Do I need to manually calculate the fluid I remove when changing the canister liners?
Again, the answer is no. It's going to know that you've changed the canister because it's weighing everything. It keeps a total in its little brain in there somewhere. So the answer is no, it's going to do it all for you.
Okay, so no, the calculation is limited and remembers the canisters removed. When we complete the MyoSure procedure and close the inflow stopcock on the scope, the Aquilex bleeps several times continuously and says overpressure. What is happening?
So basically, in the end of the scope, it's feeling pressure more than 200 millimeters of mercury. And it's probably because the surgeons turned the blue stopcock off and the circulators turned the machine on pause. It really only likes one or the other. So if it happens, either unpause it and leave the blue stopcock closed, or open the blue stopcock and leave that on pause. So it only likes one or the other, not both. And that will be why.
Okay, so the pressure has exceeded the 200 millimeters mercury safety limit and must be reduced. This is most likely caused by the hysteroscope being closed whilst operating. Open the stopcock on the hysteroscope or remove inflow tubing from the pump wheel to relieve the pressure. Right then, so questions and answer time. Now, Alan has very kindly in the background been collecting questions from our viewers, and hopefully we will be able to answer these questions. Have we had any questions in, Alan?
Yeah, I've had some questions come through, and thanks very much, Stacey and Simone, for a great run through there. Amazingly, we've only done that in 30 minutes, so I've cut our time in half, so people can get a good lunch if need be after this. So the first question that's come in is there a cut-off size of pathology that can be removed by the MyoSure?
Well, no, obviously we have different devices for different sizes of pathology. So, in all fairness, no, we can remove any polyp and large fibroids.
Now, normally for the XL scope, we would say fibroids up to 5 centimetres.
We would, but I'll be totally honest with you, I've seen much bigger fibroids removed with the XL device.
Okay, so basically it depends on which handpiece they select, and we can provide customers with a chart that will show them what each handpiece, for the light handpiece, the reach handpiece, the XL, and also the manual device as well. We can give you a table which will show you roughly what it will handle, size of pathology and type of pathology. Thanks for that, Simone. Second question is, sometimes when I turn on the Aquilex machine, the window sometimes says replace the tubing. Why is this?
It's probably because you need to turn the machine on before you insert your tubing. So you turn the machine on, it will do a systems check first. If the tubing's in, it can't go any further. It'll think you've put old tubing in it, so it'll ask you to take it out and replace it. So if that is the case, turn the machine off, take the tubing out, turn the machine back on, and put the tubing in when it's asking. So in that little window where you get all those messages, it will say insert tubing. That's when you need to insert the tubing, not before.
Thanks, Stacey. Another question is it okay to put all the Aquilex tubing on the floor rather than over the patient's leg?
Yes, we would prefer it all on the floor, to be honest. I know, particularly in theatres, everybody's like, everything up, and we understand that, but due to sort of the flow and the suction, we prefer it to be down on the floor, please.
Thanks, Simone. Another question is using an under-butter drape essential?
I'll grab that one. So it is preferred. You will get less alarms if you use an under-buttocks drape. It needs to be a decent one with a tap on it, just like something like this. There are various ones out there. I know some use the TURP drapes, and they're okay. But if you're using those drapes, you need to cut a hole in those to get to where you need to be. So if you are using one of those, and your patient's not allergic to plasters or anything like that, it's probably worth sticking it down to your patient. Otherwise, the fluid falls behind. There's some little drapes that you can stick onto the patient. And again, those ones are okay. but you need to stick them onto the cheek of the bottom, and then you need to go into the crack and then onto the other cheek. Otherwise, again, you leave a hole down the back and the fluid will pour down the back. And because that fluid's not coming back to the machine will tell you there's a high fluid loss. If you haven't got use of an under buttock drape, then you can put it in a bucket. The machine might alarm at you. You can just stick this little end into the bucket, but you'll probably need to weigh it down with something so it's not sticking outside of the water. Otherwise, again, the fluid won't come back, it will alarm. Just a word to the wise as well, if you're using a bucket or a bowl in outpatients, because it's not attached to a tap, it likes to suck. So it's like a little child sucking like the remains of a milkshake or something. So it's quite loud for your patient. So it's not essential to have an under buttock drape, but it's preferable.
Thanks, Stacey. Had a couple of questions just come in here. They've asked, are they going to get a copy of these slides? And it's just to let you know that we do have a list of all the questions and answers that we've just gone through. And anyone who's provided their email address on this session, we will automatically send you as an attachment, along with your training certificate, the copy of all those questions and answers. So just look out for that as well. And also just to remind you, if you are viewing on one device, please send us your colleagues' names along with the hospital so we can create their own training certificate as well. And if we have email addresses, we'll also send the question and answers. Another question that's come through is, are we doing face-to-face courses? The answer to that is, normally we run nurse cascade training courses, which is specifically for nurses who go back and help educate their team. Obviously, due to the COVID situation at the moment, these courses have been stopped for the moment, which is why we're trying to do these web-based sessions. If you are a consultant and you're looking for more in-depth knowledge and experience from your peers, and also some hands-on playing with the equipment and trying to morcellate some synthetic fibroids and polyps, we normally run master classes quite regularly throughout the year, but again, because of the COVID situation, they've been stopped at the moment. But as soon as we find it's safe to do so, we'd hope to start these up again. But also, the clinical application specialist team like Stacey and Simone today, they are available and they can come into your hospital if you feel you'd like some one-on-one support, so long as there's a protocol in place to keep everybody safe. And we would need an email request from the hospital, preferably the department manager, to request the presence of one of the clinical applications team or even the sales team. And we're more than happy to come in and provide a little bit more education, or if you are just starting to use the equipment and you're feeling a little bit unfamiliar with it, we're always on hand to help attend those cases and offer support by giving direction during the cases as well. Another question which has come in is, how do I reprime the Aquilex?
So can I be put on the screen?
That's it.
Yep.
Yep.
I'm on the screen, right? Okay. So to reprime, you would need the pump in pause mode. So you put it in pause, you press and hold the prime key, and then it will ask you to press the prime key. So make sure all your bags are open, make sure your scope is open, and then you just hit the prime, and that will do the prime process.
Thank you, Stacey. Another one, sometimes get air bubbles inside the uterus. Why does this happen, and how can we prevent and hopefully remove them?
Okay, so this would normally happen if you let your fluid run too low. So the wheel on the side of the machine is pumping the fluid in. If you run out of fluid, it's then just pumping in fresh air. So all of a sudden, you're getting your bubbles in the cavity, and it quite often annoys your consultant. So yeah, what we need to do is, if you know your bag's running low and you think there's a chance that you're not going to get your new bag up in time, just say to the consultant you're going to pause the machine a second, so that will stop any of those bubbles appearing in the actual cavity.
Thank you, Simone. Another question which has just come in now is, how can I know about future courses for doctors? Is there a site I can register or an email address? And just to say that once we've finished this question and answer session in a few minutes' time, we will show you the email address which you can contact us. And what we'll do is if you give us your hospital name and your contact details, we'll get one of the local representatives to make contact with you directly. And once we do know that we've got some set dates for training in the future, we'll make sure you're aware of it, and you can certainly sign up and get your name on that list. Another question which has come in is, there's a black ring that runs around the metal shaft on the MyoSure handpiece. Now, I think we touched on this earlier, but it's just, can you give some description as to why that black ring is there?
Yeah. Stacey.
Okay. Yeah. So again, I hopefully you can see this. Can I be put on the main screen? That's it. So this little ring here, so there's actually 3 black laser marks on the device itself, and what they're there for is to give direction to the consultant. So when that black laser mark is outside of this scope, on this side of the scope, it means that the cutting device is totally up the shaft of the scope, so there's no outflow. Okay, but it's for initially when they go in, this needs to be out this way, so we know that the cutting window isn't going to go into the cavity first. We put the scope in, and then they can slowly advance the cutting window. And once it goes past the shoulder of the scope, that's when it's going to come outside of here. So that's what it's initially for. But as we said earlier, when it starts to bleed, sometimes the consultant's initial response is to pull it back. If they pull it back, then they have no outflow. So all that blood is just going to sit in there. So all they need to do is just take their foot away from the pedal, find the center of the cavity, and then just let it draw any blood out naturally. Take it, because it's got a constant suction. So that's what that little black line is for.
Perfect. And I suppose the key thing to that as well is just not tapping the foot pedal. There's always a tendency, you feel that you want to suck it away. So once the cutting window is inside the uterine cavity, you feel you want to tap the foot pedal to suck that away. But what happens is the pressure drops and it starts to bleed more. So the key thing is keep it in the cavity and just wait maybe 10-20 seconds and it'll start to clear. Do not touch the foot pedal, which you feel you want to do, but please don't do it. Another question which has come in is, the MyoSure occasionally stops working. The cutting window doesn't open and close even when pressing the foot pedal. Why would that be?
So I'll take that one as well. I'll just, whilst I've got it here and I'm on camera, I'll just show you how the blade actually works. So you can see that it rotates and reciprocates, and it uses a suction to suck the tissue to that never comes inside the cavity, and it is controlled by this foot pedal and this box here. Now sometimes when you switch it on, for whatever reason, it doesn't happen that often, but you'll touch the foot pedal and there will be none of that. So all you need to do is switch the machine off. I like to take it out, and it says in the IFU 15 seconds, I like to give it 30. So you take everything out, give it 30 seconds, turn it on, plug everything back in, and then press the foot pedal, and that should have your cutting window rotating again.
Okay.
Can I just say that when we switch off, we're just switching off the MyoSure generator. We don't want them switching the pump on the top off.
Yeah, thanks, Simon. Yeah, so they're 2 separate machines. So if that happens with the foot pedal, please do not turn off your Aquilex machine, because you will have to change all of your tubing. So we only turn off the MyoSure. And again, just another tip, it tends to happen when the surgeon puts a little bit too much pressure on the blade. So they could have a little bit of pathology that's in a bit of a precarious place. So they'll push the scope one way and the device the other, and it only takes a little bit of friction for it to heat up. So it's a safety feature when it does that. It will just cut out, because it doesn't want the one to bend and perforate the patient. So it will just cut out. And sometimes, again, the consultant might put a little bit more pressure on the tissue, especially if it's a fibroid and it's got quite calcified. Remember, we don't need to put pressure on the tip. We turn up the suction at the back. So that might be why it does cut out.
Thanks, Stacey. That ties in quite nicely, actually, to another question. It says sometimes they see that the white cable from the MyoSure device kind of lashes around a little bit on some cases, and they just wondered what would cause that.
So again, sometimes we have the machine too far back, and this is too taut. So this needs to be in a nice loop, and it's always best, if possible, to have this behind your consultant. But again, if the pathology is too tough and they're putting too much pressure on, you'll see it wag like that. And remember, we don't need pressure on the device. We need to turn up the suction at the back and just adjust so that this isn't being pulled taut. We've got a nice loop from the scope to the machine.
Great, thank you very much. So that's all the questions that have come in for this session, so thank you for taking the time to answer that. I'm going to hand back to Simone just to finish off the session and close the session, and give you the email address as well for contacting us with any of your colleagues' names, and also if you want to register for any courses in the future as well. So over to you, Simone.
Right, thank you. So we've got the all the questions and the answers that we've been through today. So I think some of you may have been sent these when we did our last WebEx session, but if you want these, we will be sending them through to you anyway, I believe. Get them laminated, put them by your machine, because it would really help getting used to those, common troubleshooting problems. So I'd like to thank you for joining us today. I hope the session's been helpful to you. We have recorded the session, I think, as Alan said, so we can send it out to you shortly. If you have any comments or would like more support from the team, then please email us at ukgainsurgical@hologic.com. And if you require any more information, whether it be for MyoSure or our NovaSure system, then if you go on to insurgicalsolutions.com, there is lots and lots of information for you there. So basically, just like to say thank you for joining us today. Hope it was useful, hope it's beneficial, and have a great day. Thank you.
Thanks, everyone.
Bye.
Bye-bye.